we'll jump right into sort of talking about new technologies. And along with all of that, I've sort of been a techie for a long time. You know, I'm sitting here at my desk with my iPad, my laptop, and my iPhone, as well as my phone. So, you know, I'm sort of using all of my technologies. And we became interested at our health plan with how we could begin to leverage a wide variety of new communication technologies and techniques to improve adherence, to educate the members of our health plan and community health centers, they would be patients, and also to improve communication, because we realize that those seeking health care really move around to a variety of different settings. It's also a way, as you'll see, of overcoming some issues involving health literacy, and we'll begin talking about that. So let's start with a few points about healthcare disparities and some of the issues that contribute to health disparities. I'm sure you're all very familiar with all of these. Certainly the psychosocial issues in some quarters, the lack of societal urgency to solve the problems, cultural factors and the need to work cross-culturally, issues which are particular to communities and localities, lack of knowledge both from providers and those using health services. Certainly, lack of means is very much the feeling of hopelessness and the lack of perceived or actual opportunity, and then the issues that exist for survival skills versus advancement skills. We find often that urban residents are very good at survival skills, but not quite so good at advancement skills. The key role of racism and discrimination, the system fragmentation, and we're going to see some things about system fragmentation, and then finally educational issues and the questions of literacy, both health literacy and academic literacy. There are some myths about minorities and the use of electronic media. You hear it said that there is a gap in terms of a technology gap in terms of access. But what the Pew Foundation, who has been studying this, has found is that that gap is more apparent and real. Minorities are more likely to have cell phones. Minorities are more likely to use cell phones to connect to the internet. Those under 40 are more likely to use social media. Minorities are the heaviest users of social media. And then finally, young Hispanics are actually the heaviest users of Facebook and MySpace. So that the question then is how you leverage these new technologies, which are really very useful for people who are more mobile, and how you begin to leverage those to improve communication. And so some issues that these new communication technologies address are timely communication with the user of services. Services can be structured to be more culturally appropriate. You can address health literacy, and as we'll see with some of the things I'm going to show you, you can actually address health literacy without necessarily having to fully engage academic literacy. And you can promote continuity between systems, and then you can use them to make some improvement in the ability to predict. And by prediction does a number of different things, as we'll see later. We have a short section looking at the how predictive modeling can help in targeting the right populations who are in need of different interventions that you may want to do. So what are some of our targets? We're trying to improve data, trying to improve communication. We're trying to make information more readily available. Very importantly, as you'll see in at least one of the things we're talking about, making that information much more real-time related to when the service is needed or when it's delivered, health literacy, improving efficiency, and improving efficacy, and then using information to empower the user of healthcare. Many of us are kind of stuck in the old days. We're still looking at the wall when we should be looking at the television. And so I particularly love Gary Larson, and this cartoon really addresses the issues that some people still have with technology. So who are our targets? Well, the health service user, providers, those providing services, payors in many cases, public health, and then those who provide ancillary services which are useful but not absolutely central. What are some of the tools we're going to talk about? And we'll touch on all of these at least briefly. The internet, text messages, the vast range of apps that are available on smartphones themselves, data warehouses, which are places that you can collect data, push technology, where you use text messages or other methods to push out messages to people, alerts, and we're going to look in depth at an alert system that we're looking at using at Parkland Community Health Plan, certainly electronic health records, and predictive technology, which is itself, and then social media sites. And the last one that's not on here that we're going to talk about is we're going to talk about animation. And I've always been a huge fan of Pogo and Walt Kelly, which shows a lot about my age, because many of you who are younger don't even know who Pogo is, but almost everybody knows the wonderful phrase from Walt Kelly, "We have met the enemy, and he is us." Some of the areas that we decided to use at our health plan, and let me preface this by saying that we are owned by an integrated service delivery system, which is a public hospital. We're the predominant deliverers of services to the underserved. Our owner hospital has been a real pioneer in having community-based primary care. They have a network of school-based clinics. They provide services at the jail. They administer the health services for the homeless program. So it's not just your traditional hospital service, but much more than that. And we have been striving mightily with how we, in a very large system, how we integrate services and improve communication. So for the health plan, we set some targets of areas that were important to us. Yours may be very different, but I think it's important in terms of where we are to see what ours are. So emergency room, asthma, our population of 225,000 members who are served by our health plan, 92% are below the age of 18. So we have one common chronic disease, that's asthma. And 13% of our population has asthma. Well child care and the whole EPSDT program, which in Texas is called Texas Health Steps, child development and autism, preterm, and our population is predominantly Hispanic. And those who look at the literature know that minorities in general, and particularly Hispanics who have autism, are underidentified. Preterm birth, immunization, always a factor and probably the most cost-effective service we deliver. And then lastly, postpartum checks. Here are some of the specific tools that many of which we're going to touch on here. We are using some predictive modeling and have done some interesting work related to identification in terms of reducing health disparities, vital data technology, or VDT, CHADIS, which is a very interesting system developed by Drs. Barbara Howard and Ray Sterner at Hopkins, who are child development people, but they've made CHADIS into much more than just having to do with development. The use of animation, and we'll talk a little bit about some of the work that we're doing with Health Nuts Media. We use on-site asthma educators that we actually give to offices and to develop. Motivational interviewing is a key. We're not going to touch on much, but it's a proven technique for improving adherence, and it's very much a patient-centered approach where you really start out with the individual is figuring out what their motivations are to change. It directly springs out of Prochaska's trans-theoretical theory, which is the best method for understanding, or the best model for understanding how people change their behavior and why knowledge is not enough. By visiting a number of our primary care providers, and of course the health centers that you're in would be in that range, one of the things that we were able to glean is that our providers, including our health centers, felt that one of the things that we could provide them, we could provide them information that they did not have, and they could provide us with information because they know the patients and have the medical records, and now some of them electronic, and we have information from what happens in the emergency room, what their pharmacy filling behavior is, what other drugs they've been placed on, that the primary care provider may not directly have. And of course the question, again relating to how we address this, is how we communicate that information and make it available and secure. Patient-centered medical home, which is a great tool, electronic health records, and then text messages. And we are using two of them, which are very useful to us, and both of which are free to the health plan, so they would be, and those are also would be available to health centers, and those are Text for Babies and Assurance Wireless. And we're just getting started with Assurance, but we've been using Text for Babies in our pregnant women. It's a voluntary service. The advantage is it's free. The disadvantage is you don't have a way of counting who the users are and how much they use it. Predictive modeling, I'm going to start talking with that. That's a process of predicting future events. And basically, you can look at it in two ways. First of all, predicting the behavior of a population. On the insurance side that I'm on, very often this is used for actuarially predicting what's going to happen to expense. And it's actually a lot easier than the other, which is doing individual predictive analysis, which enables you really to do case finding and to target those who are particularly at risk for interventions, or who would be particularly amenable to an intervention. And basically what they do is they measure the power, and there are a couple of key things that you'll hear. One is the R squared, and the R squared really is a statistical determination, and I'm not a statistician, so you're going to get the non-statistician's view of it. And the non-statistician's view is that R squared is really your best single measure that says how well does this particular measure tell me that an individual is likely to be the right person to target. And the higher the R squared, the better the predictor. Positive predictive value is very important because of the fact that if you're trying to eliminate false positives, it's important to know what the positive predictive value is in a test. On the other hand, the negative predictive value is also important because you don't want to over-identify individuals. Methods. Demographic data, and demographic data, just for reference, the typical R squared is 0.05 to 0.1. So what that means is that a particular measure through demographic data has a 5 to 10% chance of being correct. of really targeting the right individual. That's pretty miserable. A lot of the early groupers used pharmacy data, and the reason they use pharmacy data is because pharmacy claims, in contrast to medical claims data, are real-time. Subsequently, people began to use claims groupers. The advantages of claims data is standardization. The disadvantage of claims data is it's really not granular enough to really help you with predicting, and but a lot of the early work was done on the insurance side, so claims data was used. And a good example is that you can tell from claims data who has hypertension, but you can't tell whose hypertension is out of control. The same thing with in diabetes. You can tell an individual's had a hemoglobin A1C or has diabetes, but you can't tell what their hemoglobin A1C level is. The neural net is another method besides the claims data, where you basically use a decision tree logic to begin arriving at your predictive value. And then some of the newer technologies use interactive data, where you're basically doing a series of predictive models and then looking at the results and then modifying them as they go along. So it's, for those who are into research, it's sort of like operational research, only using statistical techniques. And you really get much higher R-squares this way than you can get with either neural net or claims groupers. Claims groupers, and this shows the power compared to that demographic data figure that I showed you, claims groupers and neural net data typically get you in the range of a 0.4 to 0.5 according to the American Society of Actuaries. Interactives pull you more up into the 0.7 range, so they're much more powerful. And then lastly, I want to talk about psychosocial data, and all of us who've done this for a while know very well how much in all populations, but particularly in underserved populations, psychosocial factors drive outcomes, adherence, and a whole variety of other things. But we've not really been very successful at pulling that data in. There's some recent work that's been done by Ruben and Mara Singham at our owner hospital, Parkland Hospital. And Ruben has a model where he's actually been able to, Dr. Mara Singham has actually been able to pull in psychosocial data, had a paper published on predicting readmission for congestive heart failure with an R-squared between 0.7 and 0.8, which is absolutely outstanding. And when you look at Amara Singham's work, one of the things that's absolutely fascinating, when you look at the factors which he used to build up his model, one of the best predictors in psychosocial data of the patient who's going to be readmitted for congestive heart failure is the number of address changes in the last year. And from our standpoint at the health plan, and I think you folks as well, and when you're out on the provider side, you have that data, or you may have that data. And so therefore, there's a really easily measurable psychosocial measure that you can use to begin building a model if you were interested in predictive modeling. Now, I talk here about some of the targets for Medicaid, readmissions, ER utilization. We've done a lot of work around that. Developmental delay is a huge problem with us. Asthma admissions, preterm birth, complications of diabetes, and we're going to talk a little bit about identification of those children with special health care needs. Now, let's begin talking about that. There are some problems with the special health care needs children. One is there's not a universally accepted definition. The Maternal and Child Health Bureau has a definition, but it's too vague to really be all that useful. And a lot of the vagueness is defining who's at risk, because risk appropriately is a factor there, but defining risk, people who are at risk, is very difficult. The use of various different diagnostic lists are used in the states, and the diagnostic lists are always incomplete. And then there's finally the CAHMI screening tools, but there's a lot of work by Deborah Reed and others, John Neff, that shows that the CAHMI screening tools are culturally biased in a number of areas, particularly in Hispanic populations. So why children with special health care needs? High need, high use of volume of services, higher cost, need for specialized services, and 15 to 20% of the Medicaid population. And if you go to disabled Medicaid children's populations, it's 85%. So these are high needs populations where the services are very expensive and complex. The issues with identification, the lack of a national standard, the imprecision of some definitions. Diagnosis is, which is the easiest thing to find, is not necessarily to need or service utilization. When we were doing this in Kentucky, we found that 20% of those who were in the diagnosis categories that the state identified as highest need had no use of health services in the last year. And then finally, the ethnic disparities in identification, and that's sort of where we're going to go now. There are multiple studies on identification of ethnic disparities in various different states. Shenkman has looked at this in Florida and Texas, Neff in Washington State, Reed for NICHD, and she's in Oregon, and Bethel and Reed have a really nice paper on that, was published in Pediatrics. Non-Hispanic whites in a lot of populations are identified as more than African American Hispanic. In African Americans, behavioral are under-identified according to Neff's work, and Neff found that in Hispanics, asthma and behavioral issues are under-identified. And when we're talking about in Hispanics, we're saying non-Puerto Rican Hispanics, because Puerto Ricans actually have a higher prevalence of asthma identified, although they are under-identified. There's less ethnic disparity than there is in non-Puerto Rican Hispanics. The approach we used was to compare a diagnosis list we developed to the CAHMI screener, and our objective was to eliminate ethnic disparity and to find out whether the children we identified in our method were more likely to be in case management and have higher utilization of services. And so this is kind of a methodology that we use. CRMS or CMRS was one of, it's a data warehouse system that houses our claims data and anything else that we could bring in, that was developed by McKesson Corporation's information system. It's no longer on the market. There are a whole variety of others that do the same thing, and we're actually looking right now at whether doing this. The use of this data warehouse and pulling the data allowed us to use pharmacy data and claims data. Now we would also be using EHR to find those to target. And then we measured the cost and service utilization. We modified CRMS user-defined fields to include ethnic identifiers, and we reran the list by ethnic data. And you can see that our diagnosis list really vastly improved the number of people, increased by about 40% the number of people we could identify. We increased our identification and more than doubled the percentage of members that we identified. It really, but the question is, how accurate is that identification, and what does it do to the ethnic basis? And on the next slide, you'll see that using our method, we basically eliminated the ethnic disparity in identification. Now, that still leaves the question of whether you've really identified your highest using members, and our members that we identified using our technology had 5 times the average claim cost of children not in the special health care needs group. So we concluded that we really had come up with a method for eliminating the ethnic disparity using our diagnosis list as opposed to the CAHMI screener. Next topic I want to illustrate for you is reducing ER utilization in Medicaid recipients. trying to foster the medical home. What we used is we used the typology from the best clinical administrative practices from the Center for Healthcare Strategies to develop the data needs and intervention. We basically pulled together an expert group to do some definitions and to identify the targets. And then we began to do some data mining. We development of a classification system for avoidable ER use. And we tried to develop a strategy to reinforce the medical home. Our expert group, and the most easily measured, was a letter to those who used the ER 3 or more visits. And then as a second group, we identified those with 6 or more emergency room visits in a year as being what we now call chronic frequent users. And as you'll see, we're able to identify key differences between those groups and the efficacy of intervention. For those with 6 or more visits, we put in case manager calls and tried to find out what the reasons were, and sometimes that was education, sometimes it was psychosocial needs. We developed a case review process for those that we couldn't reach by phone to try and figure out how to reach them better, and you'll see some really interesting data on that in a moment. We try to improve our coordination between the health plan and our providers. And as you'll see in the vital data technology, you can begin to use technology to begin to do that. Trying to lock people in through the state program, and then in a very small number of cases, managed care disenrollment. This is really a negative incentive because in Texas, if you're in managed care, you have unlimited prescriptions. For adults and children, you don't. But we use that very, very infrequently. It's really after we go through multiple efforts, and then we have to petition the state, and it's appropriately a fairly laborious process where we have to demonstrate we've done everything we possibly can. That doesn't mean they lose their Medicaid. It only means they lose participation in managed care. And we did some studies with a biostatistician, and notice we only got to an R squared or Z square of around 0.1. It wasn't really great, but you can see some of the factors. Young age, in our population being non-Hispanic white actually was a positive predictor of becoming a chronic frequent ER user. And also season, as you might expect in our young population, winter was a factor that predicted more, and fall because of asthma. Now I want to talk a little bit about, and what we basically found in the chronic frequent user population that wasn't on the slide is that in our chronic users, first of all, it was a fabulous marker for people who had psychosocial distress, and I discovered that in a very non-scientific method. I started calling primary care providers because we noticed that a large number of those people were chronic users, contrary to our stereotypes, used both their primary care provider and the ER. They were kind of any available place where I can get seen quickly is where they were where they were going. And we actually found that the prevalence of visits in the chronic frequent users to the PCP was higher than our general population, but they used well child care about 10 to 15% less. And so it really, our being able to use the data and analyze it blew up a lot of our stereotypes about that population. Now I'm going to move on and talk a little bit about vital data technology. And by the way, if you have questions, please enter the questions as you go. I'll try to field them as we move along. Vital Data Technology is a company out of California. It's a care coordination system. What they basically use is they use claims, EHR, and other data, and they create a basic health profile for our use on our member. They could equally do it on a patient, and it allows us to create alerts to the point of service. And we're presently doing it to a number of different places: primary care providers, ER, disease management vendor, and care management vendor. As of today, We have about 44%, we're headed for 50 by the end of June, of our emergency room visits. The VDP solution is being used, and it's being used by about 25%. The providers who serve about 25% of our members. Again, by the end of June, we'll be up to 50, and at that level, we'll have a pretty robust communication system. It's a very flexible communication system, so it can flow into the provider by fax. We're integrated with Epic and one other electronic health record. We can do it by secure email. We can either do it on an individual basis. We can FTP the information. And let's see if with us, we have ER, primary care providers, our disease management vendor who does our asthma program, finds out what people have been in the ER, and they get pharmacy claims data. Our lab data, not on here, is that all our pharmacy data goes in on a daily basis, so the provider using VDP can actually get alert that says that that the asthmatic that he or she is seeing has not filled the prescription for the inhaled steroid at the point of service. We're working on getting OB and authorization and clinical information for our people who get prenatal care in one place and deliver in another place. And then finally, we're integrated with Epic, which is the EHR that's used by University of UT Southwestern Medical School, Texas Health Resources, which is the largest single hospital provider, our owner hospital and its outpatient clinics. And so by having Epic integration, we really have an integration with the preeminent EHR that's being used in the Dallas area. Now I'm going to move on, and some of the alerts that we have created or are in the process of creating are frequent ER users, people we're trying to get a hold of for case management, asthma alerts related to filling of prescriptions for inhaled steroids, that the child is due for well child care or in need of an immunization. We are also working on getting alerts that will indicate that the person is about to lose their Medicaid status, which is very important for a lot of our providers to provide continuity of care. And finally, if there's some sort of third-party liability issue where they may have a second insurance that the provider does not know about. You can see that that's a pretty broad range, and I already talked about some of the things we're doing with OB record availability or trying to develop. The next approach that I want to talk about is CHADIS. CHADIS was developed, as I said, by Barbara Howard and Ray Sterner, two physicians at Hopkins. It's a web-based screening, diagnostic, and management system originally developed for children with developmental, but they now have an asthma component. It integrates with EHRs. There's a parent portal that has really useful information, also available in multiple languages. They have all of the screening tools for developmental behavioral disorders, including autism. For the American Academy of Pediatrics, participation in CHADIS can be used for maintenance of certification for providers. It includes the health multimedia data that I'll talk about later for asthma, and for the PCHP, we are in the process of contracting to use it to link the PCP to the health plan and to therapy providers for children who are receiving speech therapy, physical therapy, and occupational therapy. Because one of the things our providers complain about is once they go into those systems in Dallas, they're lost for the provider. The provider just gets this request to let me do my therapy, to get therapy for another 6 months without the ability to see the child, to monitor what's happening. So it really gets in the way of the medical home. We're also talking about using it for attention now, within the last week or so, using it for children with attention deficit disorder. One of the other things that's not here also that CHADIS has available that we very much like is, for those who are familiar with the MCHAT, which is the autism screening test, it has a very high positive rate. Dr. Sterner and Dr. Howard have developed an observational questionnaire that the physician can do or nurse can do at the point of service and virtually rule out all the false positives by observing the child, and it's a validated instrument. In the asthma component, many of you may be familiar with the asthma screening tools, the ATTACK and the ACT, the asthma control test, and the pediatric version, the pediatric asthma control test, which are the recommended ways for following control and acuity in asthmatics. The problem with those particular tools is that they do not lead the provider who's not familiar, who is unfamiliar with the NAEPP criteria to the proper therapy. They tell you what the symptoms are, but they don't really lead you to therapy. A researcher at Hopkins has developed a simple tool that tells you, a tool like the ACT, which shows you, leads you into, this is a moderate, a moderate persistent asthmatic, and therefore this is the recommended therapy. So it kind of bridges that gap. That's available in CHADIS and almost nowhere else. Now I'm going to talk a little about Health Nuts Media because we're getting along in time. And Health Nuts Media is an animated health education media tool for children. I became involved with them around the development of the Huff and Puff asthma video, which is now out and available in English and Spanish. They also have a common condition series. And one of the things that I pointed out is I said, who is this for? And they said, well, it's to educate the children. I said, no, it's also to educate the parents, because we have an awful lot of parents whose academic literacy and health literacy is very low. And by using animation, and by the way, for those of you who are like myself, a little bit older, younger population, by which I mean people under 40, there are an awful lot of people who are really into animation and animation series from, the time that we're kids until we go into adulthoods. When we're kids, we watch Barney, we watch animation stuff on TV. When I grew up, it was Mighty Mouse and Superman, and now it's other stuff. And now, when you're an adult, an adolescent, you probably watch something like Avatar: The Last Airbender. And then when you get a little older, an adult, you watch South Park and The Family Guy and things like that. So we've really seen the expansion of animation as a tool. So why not harness that tool? And of course, people are also into games, and Health Nuts Media is busy developing some tools for that. We're very excited about that in a bit. Actually, it's time, and we're going to show one of the videos. This is the introductory on the asthma series. Before we show that, I want to say that as well as being really, let me see it, and then I'll make a couple of comments. We'll let you watch this for a little bit.
So, Lauren, we're here today to learn all about asthma.
That's right, Daniel. There's a lot to know.
Oh, in that case, let's do the story about when the big bad wolf found out he had asthma. 'Cause who would expect coughing and wheezing from the most famous huff and puffer in the world?
Once upon a time, there was a big bad wolf.
But one day, something went terribly wrong.
Get set. It's on.
Hey, little pig, let me come in.
Not by the hair on my chinny chin chin.
Then I'll huff and I'll puff and I'll blow your house in.
But the wolf didn't blow the house in. He couldn't huff and puff like he normally did. In fact, he felt like he could barely even breathe.
What's going on?
It's a trick! Don't fall for it!
I don't think so. Look! I think you lost your Huff and Puff.
Lost my Huff and Puff? You're right. Don't make me laugh.
Come on, we've got to get you to a doctor.
I don't need a doctor. I'm the big bad. Okay. Get me to a doctor.
Well, are you feeling better now?
Yeah, I am.
So, you cough even when you're not sick?
Uh-huh, I do.
Do you get short of breath easily?
Yeah, I have lately.
Do you seem to get tired quickly?
Yeah, especially when I'm working, trying to huff and puff.
And your chest feels tight?
I have been feeling that recently.
Mm-hmm. Well, these are signs and symptoms of asthma.
Huh? Asthma? What's that?
What? So, now, am I going to get it too?
No, Jigs. You can't catch asthma from someone else. Don't worry. The doctor will tell you if you really have asthma or not. But even if you do, there's lots of things we can do to help.
Hey, what if... Nah.
What if what?
What if you blew your own house in, and I kind of stood behind you, like it was me that did it?
No.
Oh, all right, forget it. Bad idea.
Before we know if the big bad wolf has asthma, the doctor has to make an official diagnosis. That's what doctors call it when they figure out what's causing your symptoms.
Symptoms? What are those?
Glad you asked, because that's our next episode, Signs and Symptoms.
One of the things that I've been talking to them about is developing some specific content that's aimed to the needs of our population. For instance, one of the big reasons that we see for people going to the emergency room is the lack of self-management skills around upper respiratory illness and around fever. And that's tied up in some issues related to health literacy, because people don't understand the difference between 100.6 and 106. So we're in the process of talking about development of that. But the series that deals with health issues of 13, now this particular sequence is 7 segments. It runs about 30 minutes. Most of their stuff runs 3 to 4 minutes, so it's very, you can break it. And this particular, you noticed, is episode 1. We deliberately broke this up into small chunks so you didn't have to watch the thing at the same time. The other stuff is all small. It's a small chunk. It's a 3 to 4 minute segment. So yes, there is other stuff available. The other thing is that there is some stuff that's available in game content. As you know, kids and adolescents and some young adults are very into game content, particularly on smartphones. And so there is some game content that's available from Disney and Warner Brothers, and we're interested in developing further that relates to the Health Nuts Media series. And you can find them on the web at healthnutsmedia.com.
Can you repeat the name of the website?
healthnutsmedia.com.
Okay, great. Thank you. Another question that we have here is, how can we get, this is from a grantee, how can they get access to the questionnaire that you described earlier that was produced by Dr. Sterner and Dr. Howard?
Oh, CHADIS, again, that wonderful tool, the internet, CHADIS.com. And you can contact. Now remember that both of these are commercial sources, so they do have fees associated with them.
Okay, great.
But one of the things, and I didn't mention this, what we're going to do in our health plan is we're going to pay the licensing fee and give CHADIS to to 100 to about 100 of our 129 of our primary care providers, including the FQHCs in our area. So we're going to pay the license. We're doing the same thing with Vital Data. We're paying it. There's no cost to the end users. And our arrangement with Health Nuts Media, because I was involved in development of the asthma video, I get access and I'm able to disseminate it widely in my network. So to me, it's free.
One of the health centers, Dr. Lachman indicated that they enjoyed the way that you presented the data, that you were able to eliminate the disparities. They wanted to know, apart from the methods that you are currently using, is there anything else that they should consider in serving their rural communities where they may not have that continuum of care with their patients? Or if you have any recommendations.
A couple of comments. One of the things that we're beginning to see, I think, from what we're seeing in Texas, the rural areas are lagging more, is that the Health Reform Act has a really, the Affordable Care Act really has a lot of emphasis on collaboration. And we are now beginning to see providers coming to us to talk about collaboration between insurers and health plans. And Blue Cross in Texas is really doing a lot of this as well. We're seeing some of it from Cigna. I think people need to really begin thinking of their insurers in a different way than they've had it before. Though the guys who have mostly been just saying no in the past, even if health reform is thrown out by the Supreme Court, are really going to have to change their methods in order to succeed, because we're really entering an era of collaboration. And so the question becomes, who can you collaborate with to get data, to link data together to begin breast serving? And then, the other problem you have in rural areas is, how do you communicate, particularly because some of the technology tools in terms of the internet and smartphones, in rural areas, your services may not be as good or as robust. And so I think there are some increased barriers in the rural area. I hope I answered the question for you.
Yes, well, it gives us actually some things to think about it, how we can help grantees like this particular health center connect, to meet some of those challenges that you described. Again, if you do have any further questions, feel free to type them into the Q&A box if you have not already done so. And Dr. Lachman, also, we will provide your presentation as well as an audio version on our website following this webinar. And if it's okay with you to share in case other individuals may have some questions, if they can contact you directly, or can you let me know what is the best form of contact for you?
Email.
Okay, great. All right. So if there's I think some folks may have some questions further on some of the issues that you did discuss in here. So we will provide that information so that they can contact you. Again, we're very, very close to our time, and we do thank you so much, Dr. Lachman, for your time today. I think this was very, very educational for many of our grantees, and it has helped us think of some other things that we can do to eliminate health disparities in the various clientele populations that we're serving, especially in public housing. And we're delightful to learn about some of these new communication technologies that can help our health center grantees overcome some of those issues. So we do know we are going to be looking forward to having some more webinar topics in the future on managed care and ACOs with Dr. Lachman. And so we will make sure that we send that information to you out as well. So please stay tuned for those webinar announcements as well. And if you have any further questions related to this topic, or any others that we can assist you with, please contact us here at the National Center for Health and Public Housing. You can reach us best by email, www.nchph.org. Feel free to fill out our training and technical assistance form on our website, and we'll be delighted to respond as soon as we can to get you the answers that you need. In addition to that, I do want to remind everyone, if you have not already done so, please join our mailing list, and you would receive frequent information on all of our upcoming events and all that we have to offer you. So everyone, thank you again for joining us today, as those on the East as well as the West Coast. Dr. Lachman, thank you very, very much. We do have a post survey that we're going to send out that at the end of this presentation that we ask all of you to please kindly fill out and send to us as soon as possible. This gives us an opportunity to address further issues related to these topics. So again, thank you everyone for joining today's webinar.